The following PowerPoint will provide information regarding a quality challenge that Southeastern Health is currently experiencing. The importance of quality checks and indicators in the healthcare system cannot be underestimated. Hospital readmissions are penalties that are accumulated during the fiscal year of October the 1st through September the 30th. The readmission penalties are based on the diagnoses related group, or DRG, assigned to the patients during their inpatient stay. Penalties can be from 1% up to a maximum of 3%. Readmissions are those patients that are admitted to an inpatient prospective payment system or an acute care hospital within 30 days of discharge, or another IPPS acute care hospital during the same 30-day period. Readmissions could either be planned versus preventable. Planned readmissions are based on patient condition, diagnosis, prognosis, or a discharge plan that's been provided by a medical team or interdisciplinary team. An example of a patient that may have a planned readmission could be that of a patient with congestive heart failure, kidney disease, and diabetes. This patient may be discharged to an in-home setting. However, their intervention or treatment regimen may require that of an inpatient facility, such as dialysis. Many times, these patients are set up with home health aides or some type of health care assistance. However, many times interventions may not be able to be provided within the home. However, preventable readmissions are those readmissions in which healthcare organizations accumulate penalties for, because preventable readmissions could be noted as a discharge plan that was not adequately standardized. Many times with preventable readmissions, we find that no follow-up appointments were made and suboptimal care during the treatment or discharge process for the patient was incomplete. According to the Centers for Medicare and Medicaid, which is CMS, 19% of Medicare inpatients are readmitted within 30 days post-discharge. 90% of those readmissions are unplanned. The cost to Medicare is approximately $17 billion annually. Penalties are accumulated for the following diagnoses for patients that readmit within 30 days: congestive heart failure, stroke, chronic obstructive pulmonary disease, COPD, acute myocardial infarction, AMI, pneumonia, total hip and knee replacement, or coronary artery bypass grafting. Currently at Southeastern Health, we have interventions in place to help reduce readmissions and decrease penalty. Our primary focus is on improving care transitions. By improving care transitions, we are identifying high-risk patients when they are presenting to the emergency department and using a systematic approach when providing care. Not only are we utilizing services within our own organization, but we are reaching out to community partnerships, helping to establish relationships in order care can be maintained in a community environment, which will help to decrease readmissions. Within the last 18 months at Southeastern Health, we have established a transition team. The transition team includes 3 registered nurses, a paramedic, and a pharmacy tech. The goals of the transition team is to help the patients transition from hospital to home, to provide tools to help maintain better health at home, to decrease hospital visits, to follow patients for at least 30 days at absolutely no cost to the patient. The transition team monitors data on a daily basis to ensure that all Medicare high-risk patients that have a core measure diagnosis are identified. Once Medicare core measure patients are identified, a face-to-face is provided to the patient by the transition team while in the hospital. Once the patient discharges, a phone call by the transition team is made to the patient and/or family within 24 hours. The transition team then, within 72 hours, makes a home visit to the family and patient in order that education is provided, that medication reconciliation is understood and vital signs are taken in order that symptom management, interventions, and follow-up appointments are discussed and understood. As Southeastern Health continues to focus on readmissions, we will seek to achieve clinical excellence and invest in quality improvement strategies. Going forward for 2017, we feel it's important that we establish partnerships with primary care physicians and other physician groups, and we collaborate with local facilities to include SNF nursing facilities, nursing homes, assisted livings, and rehabs. Medication management has to be provided and maintained within our own organization as well as community pharmacies. Follow-up appointments have to be made, education has to be provided, and never-ending communication between patients, families, and staff. In effort of transparency, I have provided the readmission data for Southeastern Health. The following information is from the time period of August 2015 through July 2016. The congestive heart failure benchmark set aside by CMS is 22%. This is inclusive of Medicare patients age 65 and over that have readmitted during this time period. Currently, our percentage is 29.7%, which is 8% deviation from target. Our hip and knee, also for the same time period to include Medicare patients ages 65 and over, are 12.5%, which is 8% deviation from target, as the national benchmark for hip and knee set aside by CMS is 4.8%. The national benchmark for AMI by CMS is 16.68%. Currently at Southeastern Health, we are at 24.10%, which is also a 7% deviation from target. Our COPD percentage is at 25.72%, which is 6% deviation from target, as the CMS national benchmark is 20%. The national benchmark for pneumonia for Medicare patients age 65 and over is 17.1%. Currently at Southeastern Health, our pneumonia percentage is 2% deviation from target, as we are at 18.92%. The Southeastern Regional Medical Center's readmission stroke percentage is at 17.28%, and the national benchmark is 12.5%, which is also a 5% deviation from target. The national benchmark for the CABG procedures for Medicare Part A, ages 65 and over, is 14.9%. However, Southeastern Health exceeded that target by 6.1%, as we are currently at 14.29% for the time period of August 15th through July 2016. This is the quality scorecard reflecting the information that we submit to CMS regarding hospital readmissions at Southeastern Health. As much of the scorecard is the information that's already been provided, I did want to point out the overall hospital readmission benchmark by CMS is 15.2%, and currently at Southeastern Health we are at 18.96%. As we continue to strive to decrease readmissions and, of course, decrease our penalties, it's very important that we continue the momentum that we have established by our transition teams and our partnerships within our own organization as well as community to decrease our core measure readmissions in 2017. As we're preparing for 2017 and what our readmission goals should be, this is the readmission proposal number 1 that Care Management has provided to administration. We are proposing that we continually decrease our CHF readmissions by 2%, as well as continue to decrease our hip and knees by 2%. This proposal was made due to the fact that our CHF had a deviation of 8% for the year 2016, as well as our hip and knee. Our second readmission proposal to administration, along with the CHF target to decrease by 2% would be to decrease our COPD by 2% as well. Although our COPD had a 6% deviation from 2016, we feel as a transition team and as a care management department that we have more influence and more involvement now with the pulmonary team and other interdisciplinary teams throughout the organization that we can affect the readmission goals for the upcoming year. As hospital readmissions continue to be an ongoing challenge for Southeastern Health, the nurse leader will have a pivotal role in reinforcing and encouraging the reduction of hospital readmissions in the future. Because of the roles that the nurse leaders are tasked with, they should be at the forefront in ensuring that their actions help in eradicating the preventable hospital readmission. As hospital readmissions have presented opportunity, it has also allowed for collaboration, communication, and execution of standardized processes impacting the entire organization. As explained by Porter, O'Grady, and Malik, leaders will have the responsibility and accountability to adapt to an unfamiliar infrastructure while engaging and embracing opportunities to influence quality outcomes.